In this session, we shall learn about the basic techniques for administering local anesthesia in the oral cavity. As you would know that local anesthesia provides the main option for achieving pain control in invasive dental procedures, and it is a core skill you will need to master as a dentist and dental therapist to provide painless dental treatments to your patients. The learning objectives for undergraduate training in local anesthesia are as follows. You should have a good and thorough understanding of the applied regional anatomy related to the administration of local anesthesia in the oral cavity, and I've recorded a separate plenary on applied anatomy of local anesthesia, which should be available to you on the DLE. You should also have a good knowledge of the applied pharmacology related to local anesthetic agents so that you can make a choice of the appropriate drugs to deliver painless dental treatment. And there should be another plenary on the DLE on the pharmacology of local anesthetic agents, the safe assembly and use of LA equipment, and the main topic for this session would be learning basic injection techniques for administration of local anesthesia in different regions of the oral cavity. There are three main methods of obtaining local anesthesia. First is surface or topical anesthesia, which is mainly aimed at minimizing the pain associated with injections, and you would normally utilize a topical anesthetic gel or liquid which is applied on the surface mucosa uh, at the site where you plan to inject, and the technique is fairly straightforward and you should be able to learn it without any difficulty. The second technique is infiltration anesthesia, which requires use of a needle. Infiltration anesthesia aims to anesthetize the most terminal branches of a nerve close to the site where you plan to intervene. So, for example, if you wanted to treat the upper left central incisor, you would inject close to the root apex of the upper central incisor and anesthetize a single tooth. Obviously, the area anesthetized by infiltration anesthesia is quite small, and but the technique is quite simple and straightforward. Uh, and even as a beginner, you would be able to demonstrate over 95% success rate with infiltration anesthesia. There are multiple types of infiltration anesthesia. What is demonstrated in this picture is a labial infiltration, which is aimed to be supraperiosteal. You want to inject underneath the mucosa but stay above the periosteum, because if you inject underneath the periosteum, the anesthetic liquid would strip away the periosteum from the bone, and that would be excruciatingly painful for the patients. So the simplest infiltration anesthesia is a labial or buccal infiltration. You can also perform infiltration anesthesia into the interdental papillae, which is known as a transeptal infiltration, or into the gingival sulcus, which is known as a periodontal or intraligamentary infiltration. Likewise, you can inject directly into an exposed pulp during endodontic treatment, or cases where the pulp is exposed as a result of trauma. However, the commonest type of infiltration you would be administering would be a supraperiosteal, labial or buccal infiltration, or a palatal infiltration, and we'll discuss these later in the presentation. Regional anesthesia or a nerve block is the third method for obtaining local anesthesia and basically involves anesthetizing the main trunk of a nerve, and as a result, all branches of that nerve are anesthetized. So, just to apply it to the oral cavity, if you were to anesthetize the inferior alveolar nerve, close to the mandibular foramen using an inferior alveolar nerve block, you would be able to achieve anesthesia of the entire mandibular dentition on one side, along with anesthesia related to the buccal soft tissues anterior to the mental foramen, uh, the lower lip, and the chin. So, if you want to anesthetize a wider area with a single injection, that is when you need a regional nerve block, or if you want to anesthetize a specific area where infiltration anesthesia would not work, that is when you would need a nerve block. Uh, whilst nerve blocks are quite useful, they are technique sensitive, and as a beginner, you might experience uh, frequently that your nerve blocks are not being successful. That's perfectly normal, and it's something you would learn over a period of time. Even with experienced practitioners, there is a risk of 10% failure uh, of inferior alveolar nerve blocks. So it's something which needs to be mastered over a period of time. We shall now look at the equipment you would need for administration of local anesthesia in the oral cavity. Obviously, you'll need your full PPE that includes your apron, gloves, mask, eye protection, and eye protection for your patients. You would need some form of topical anesthesia, which would usually be a gel. You also need your LA syringe and needle, and this is the Safety Plus syringe. That's one what we would be using on clinic, which has a separate needle assembly and a separate handle. Obviously, the needle assembly is disposable, single use only, whereas the black handle with the piston is it can be autoclaved and needs to be reused. You're not going to throw this part away, and you would need your local anesthetic cartridge. Uh, you also need access to a sharps bin to dispose of your uh, needle assembly as well as the used local anesthetic cartridges. And ideally, you should also have on your tray an artery forceps, either a straight artery forceps or a curved artery forceps, also known as mosquito's forceps, just in case when you're administering an injection in the mouth and the needle breaks, before it disappears in the soft tissues, you are able to grab the broken end of the needle with a hemostat. So that's quite a useful piece of instrument just in case you break your needle. It isn't normally available, but it's, for safe practice, you should always have one by your side just in case the needle breaks. The needle assembly you would be using for administration of local anesthesia during your training in the dental education facilities is the Safety Plus syringe and needle, which comes as a separate uh, pre-packed sterilized needle assembly with the plastic housing to accommodate the anesthetic cartridge and a separate uh, black handle. Obviously, this part is to be retained as it can be autoclaved, but the needle itself can be disposed after single use along with the used anesthetic cartridge. Uh, there is a separate video demonstration which you should watch to look at how to use the Safety Plus syringe, the advantages, the benefits, the safety features, how to unpack the Safety Plus needle, how to load the cartridge, how to put it in the holding position, and how to put it in the locking position to dispose it after use. So all those elements have been discussed in the video demonstration, which should be available to you on the DLE. The needles for dental local anesthesia, that is the Safety Plus uh, needles you would be using, are made up of stainless steel and they come in sterilized individual packings which you need to unwrap. They're disposable and for single use only. For infiltration anesthesia, you would be using a blue needle, which is also known as the short needle, 25 millimeter in length and has a diameter of 27 gauge. Whereas for regional anesthesia, mainly the inferior alveolar nerve block, you would be using a yellow needle, which is the long needle, 35 millimeter in length and 27 gauge in diameter. Administration of local anesthesia in clinical environments carries a recognized risk of needle stick injuries, and your focus should be really on prevention of these injuries in the first place. Safe and appropriate use of safety plus syringe, as is practiced in the dental education facilities, reduces this risk to negligible levels, and unless you're really careless, you should not encounter any needle stick injuries, and we shall train you further on these during your clinical sessions. In any case, you should familiarize yourself with the PDSC protocol on the management of inoculation injuries in the dental education facilities, and you can look at these protocols on the PDSC website. And safe use of LA equipment and disposal of the sharps will be tested as part of your competency in LA. We shall now look at some of the key steps of LA administration. The first and one of the most important one is patient position during LA administration. Now for all injections, your patient should be laid flat in the dental chair, that is they should be in a supine position. For all LA injections, that includes infiltrations and nerve blocks both in the maxilla and the mandible. And there are two main reasons for using the supine position. Firstly, you would know that the commonest medical emergency in dental practice is vasovagal fainting, and uh, the predisposing factors for vasovagal fainting during dental treatment are fear, anxiety, and pain. And you can imagine that the most likely time these emotions may be evoked would be around the time of LA administration. So if you have your patient supine in the dental chair, the risk of vasovagal fainting is minimized significantly, and should a vasovagal attack may occur, it may be self-corrective. And secondly, what you need to do is during your LA administration, ask the patient to wiggle their toes and take deep breaths, and that keeps their circulation going and also distracts them. And also maintain a good eye contact with the patient and work out hand gestures so they can stop you should they get uncomfortable. So that's one of the most important ones. Please ensure that for all LA injections, you use the supine position. And when we have face-to-face sessions, I can elaborate further on this. Secondly, of course, like almost everything in dentistry now, use a sterilized needle, which is single use. So whilst you may be able to use the same needle for repeat injections on the same patient, should you be treating a patient with an acute infection like a dental abscess, it's best not to reinsert the needle if it has been used close to the site of an abscess. So you may want to use a new needle. Before you take the cap off the needle, the plastic cap, check the flow of the LA to ensure that it's working properly. Apply topical anesthetic, which may be benzocaine gel, which is the pink gel, or the Xylonor gel, which is the off-white gel. The important thing is that when you apply the topical anesthetic, you must wait for up to 2 minutes. If you were to go and inject at this site within the next 10-15 seconds, the topical anesthetic might not have taken its full effect. So that's really important. When administering buccal infiltrations, you would find that if you retract the lips and the cheeks to make the tissue taut, the injections are less painful. Obviously, that is not possible when injecting in the when injecting on the palate, because palatal mucosa is mucoperiosteum and you can't stretch it. Then obviously you would administer your injection by inserting the needle into the mucosa. And at this point, you must aspirate. And one of the key advantages of the Safety Plus syringe is that aspiration can be elicited predictably uh, if you know how to use the LA syringe, Safety Plus syringe. And this was not possible with the traditional metal syringes we've used as dental students and clinicians over the last 15-20 years. Safety Plus syringe does allow you uh, to aspirate predictably and effectively. So ideally, you should aspirate for every single injection, including infiltrations and nerve blocks, but certainly for ID nerve blocks or for any other nerve blocks you're going to administer, aspiration is essential. Then you would deposit the LA slowly. Now, this slowly is important because the rate of administration is going to determine the amount of discomfort your patients would experience. So, for ID nerve blocks, you should take anywhere between 30 seconds to up to a minute, and that is quite a lot of time. So, you have to be very patient. Similarly, with infiltrations, uh, when you inject about zero point 0.5 mils, um, it should be administered over a period of 15 to 30 seconds, not within a couple of seconds. So that's something you would have to be very patient with. And then you withdraw the syringe slowly, and then very importantly, let the local anesthetic work. If you were to start your treatment straight away, obviously patients would start feeling a bit tingly straight away. Most patients would, but that doesn't warrant treatment straight away. Wait for a good 3 to 5 minutes so that the LA is fully effective. Confirm it with the patient both by asking them if they feel numbness or tingling in that area, and also by using a blunt instrument, pinching the soft tissues just to ensure that the patients are pain free. Obviously, the pressure sensation would still be there, but they should not experience any pain. And finally, what is very important throughout LA administration is that you must communicate and observe the patient throughout the procedure. Maintain good eye contact, which would allow you to gauge if they are getting too uncomfortable or if they are experiencing any medical emergency. So that's really, really important. And the communication is also important to reassure the patients, explain to them what you're doing, what they should expect. And then you would have, patients who don't want to hear anything. So that's something you would work with them, work out prior to administering the LA. But in any case, good, effective communication is very helpful in most patients. Now, one of the most common factors associated with dental phobia is the fear of dental injections. That's what stresses most patients. And perhaps it's the dream of every single dentist that if they can deliver painless injections to their patients, they'll certainly be very popular. So, some of the things which may help you minimize the discomfort associated with uh, local anesthetic injections in dental practice are firstly the use of surface anesthesia. Now, surface anesthesia is usually very helpful with infiltrations. It may not be so effective with ID nerve blocks, but the least it does is it reassures the patient that you are caring and you are trying your best to look after them. So, our policy at the dental school is that you would use topical anesthesia for every single injection. Um, it's best to use cartridges at room temperature. Obviously, if the cartridges are stored in the refrigerator, uh, the cold temperature of the local anesthetic injection can make it a bit more uncomfortable. So it's best to use cartridges at room temperature. And as discussed in the previous slide, it's very, very important that you inject slowly and that you explain to the patient before you start administering the LA that you would be injecting slowly as it would help minimize the discomfort they might experience. Uh, Now, this one is really, really important. When you inject uh, into the oral cavity, you want a supraperiosteal infiltration. That is, you do not inject underneath the periosteum, you inject above the periosteum. If you were to pierce the periosteum and introduce local anesthetic fluid underneath the periosteum, it would strip away the periosteum from the bone and it would be excruciatingly painful. So when we look at the techniques for local anesthesia, we'll discuss how best to avoid a subperiosteal injection, and we'll talk a bit more about it. Obviously, this is unavoidable on the palate because the mucosa is directly bound with the underlying periosteum, so it's mucoperiosteum, and also in the region of the gingival mucosa, you have mucoperiosteum, and that is precisely the reason why palatal injections are considered to be the most painful. However, there are other ways you can minimize pain from palatal injections, and we'll talk a bit more about it in a minute. Now then, again, as discussed in the previous slide, allow sufficient time for the LA to work, and at least 3 minutes is the bare minimal that you would allow from the time of completion of the injection and start of your uh, operative treatment. And finally, communicate and reassure the patient throughout their uh, treatment session. We shall now look at the techniques for administration of local anesthesia in the maxilla, and I would urge you to consolidate your anatomy knowledge by looking at some of the life sciences sessions we did earlier on the anatomy of the trigeminal nerve, and also you should have access to one of my other plenaries on anatomy for local anesthesia. It should be available on the DLE. Uh, just very briefly, the nerve supply to the maxillary teeth is provided by the posterior superior, middle superior, and anterior superior alveolar nerves, which are branches of the maxillary nerve. The posterior superior alveolar nerve is a branch of the maxillary nerve in the pterygopalatine fossa, and from there it descends along the posterior border of the maxilla along the maxillary tuberosity and pierces the maxillary cortex to supply the pulps of the maxillary molars, excluding the mesiobuccal root of the upper six. The posterior superior alveolar nerves also supply the buccal cortex related to the molars, the buccal periosteum, and the buccal soft tissues related to the maxillary molars. The anterior and middle superior alveolar nerves, they branch from the maxillary nerve as it crosses the infraorbital canal in the floor of the orbit, and then the anterior and middle superior alveolar nerves, they descend along in the anterior wall of the maxillary antrum. The anterior superior alveolar nerves provide innervation to the pulps of the incisors and canines, and also supply the labial cortex of the maxilla related to the incisors and canines, the labial periosteum, and the labial soft tissues, including the vestibular aspect of the upper lip, the mucosal aspect of the upper lip. Um, the middle superior alveolar nerves, they provide innervation to the pulps of the maxillary premolars and the mesiobuccal root of the upper six, and they also provide innervation to the buccal cortex, uh, buccal periosteum, and buccal soft tissues related to the maxillary premolars. So all the nerve supply to the pulps of these teeth is maxillary teeth is via these three branches. As maxillary bone is quite porous, especially the buccal cortex, the LA solution is able to diffuse readily through the maxillary bone and reach the apices of the teeth. Therefore, most restorative procedures, such as fillings and root canals, can be accomplished by buccal infiltration alone, and you do not necessarily need nerve blocks in the maxilla. For tooth extractions, in addition to the buccal infiltration, you may also require using standard techniques, you would require a palatal infiltration as the extraction forceps often impinge on the platal soft tissues, so separate platal infiltrations are required, which we shall discuss in the coming slides. We shall now look at specific injection techniques in the maxilla. As mentioned in the previous slides, infiltration anesthesia is usually adequate for most dental procedures in the maxilla. So for restorative procedures such as fillings, crown preparations, root canals, buccal infiltration anesthesia is usually adequate in the maxilla. And if you were to perform tooth extractions, you would also require palatal infiltrations, which we'll discuss in detail in a moment. Uh, so on the whole, you would only need to master infiltration anesthesia for routine dental care. Nerve blocks can be used in the maxilla uh, under specific circumstances, and these include the infraorbital nerve block and the posterior spiri alveolar nerve block, which are administered from a buccal approach. And then you can also anesthetize the main trunk of the nasopalatine or incisive nerve, as well as the greater palatine nerve. However, you would not require these for your routine dental care, and we shall only discuss these very briefly at this point, and it's something you would consolidate in the later stages of the course. Routine dental treatments such as restorative procedures and tooth extractions of the incisors and canines in the maxilla can be accomplished by infiltration anesthesia. So basically, you are aiming to anesthetize the terminal branches of the anterior alveolar nerve close to the root apex of the tooth you are interested in working on. Uh, so you would follow the same standard procedures, steps. You would apply topical anesthesia close to the injection site, then gently stretch the mucosa by pulling the lip and the labial soft tissues, and you're aiming to inject close to the root apex of the tooth, just shy of the mucobuccal fold. Um, so penetrate the mucosa with your local anesthetic syringe with the bevel of the needle facing the bone towards the root apex, and then you would infiltrate a few drops. And the key thing is that you should place the needle parallel to the long axis of the tooth. Parallel to the long axis of the tooth. Don't try to come at right angle to the tooth or perpendicular to the tooth, because then you are more likely to give a subperiosteal infiltration, which is not desirable. So in order to inject supraperiosteally, you would place your needle parallel to the long axis of the tooth. This is the key thing. And you are aiming to inject close to the root apex. And if you are in doubt, just inject fractionally shy of the mucobuccal fold, and you only need a few drops, so roughly zero point 0.5 mils is usually adequate. Um, and prior to infiltration, ideally you should aspirate, even though it's not absolutely critical for infiltrations. Certainly it is for nerve blocks, but it is always best to aspirate, and then slow and gentle injection of say zero point 0.5 mils over 15 to 30 seconds. So it's a very simple technique, and even with beginners has over 90 to 95% success rate. And you should, feel confident in providing simple infiltrations, because they are not uh, hugely demanding in terms of the technique involved. It's fairly simple and straightforward technique. The technique for buccal infiltration in the premolar region of the maxilla is very similar. So you inject close to the root apex of the premolar you're working on, and in order to do that, you would place your syringe parallel to the long axis of the tooth and inject close to the uh, root apex of the tooth. And again, you only need to inject a few mils roughly 0.5 mils for buccal infiltrations in the maxilla. The technique for buccal infiltration in the molar region of the maxilla is also very similar. Place the needle parallel to the long axis of the tooth and inject close to the area of the root apex, just fractionally shy of the mucobuccal fold. And again with buccal infiltrations, whether in the incisor, premolar or canine region, or the molars, you only need to penetrate a few millimeters into the mucosa. You don't need to, insert the full length of the needle. Just 3 to 4 millimeters of needle penetration is usually adequate. One of the recognized blocks in the maxilla is the infraorbital nerve block. It's also known as the anterior superior alveolar nerve block. So as you would know from your anatomy knowledge, that the maxillary nerve travels in the floor of the orbit as the infraorbital nerve, emerges through the infraorbital foramen, which is located below the infraorbital rim, and divides into its terminal branches. So the termination of the maxillary nerve can be anesthetized by giving an infraorbital nerve block in the region of the infraorbital foramen. The block is administered intraorally and, when effective, results in anesthesia of the incisors, canines, the premolars, the mesiobuccal root of the upper six, and also all the labiobuccal soft tissues, plus the upper lip as well as the cheek. Um, this nerve block can be useful when carrying out treatment on multiple maxillary teeth, such as a dental clearance, or when local anesthesia may not be effective due to the presence of acute infection such as an abscess, and you don't want to inject into the abscess, so you can use the infraorbital nerve block. You're not going to use it routinely, so we will just mention it briefly here, but over the years we shall provide you with opportunities to administer infraorbital nerve blocks as and when appropriate. Another nerve block in the maxilla is the posterior superior alveolar nerve block. Um, and it is also administered intraorally by orienting the needle at 45 degrees to the buccal aspect of the maxillary second molars and inserting the needle for about 1.6 centimeters, so that the main trunk of the posterior superior alveolar nerve is anesthetized. And when effective, the posterior superior alveolar nerve block will provide anesthesia related to the maxillary molars, excluding the mesiobuccal root of the upper six, the buccal bone, and the buccal soft tissues related to the molars. And again, the indications are similar as with infraorbital nerve block. So if you want to operate on multiple teeth, or if there is an abscess related to one of the maxillary molars and you want to avoid injecting directly into the abscess, you can use the posterior superior alveolar nerve block. Uh, and again, uh, these nerve blocks in the maxilla are not required in routine dental practice and is something you will learn in later stages of the course as and when appropriate. Now we shall briefly review the anatomy of the palate. The anterior part of the hard palate is supplied by the incisive nerve, which is transmitted through the incisive foramen, and it supplies the palatal soft tissues related to the incisors and canines. Obviously, it doesn't supply the teeth, but it does supply the palatal mucoperiosteum and the palatal bone. Whereas the palatal soft tissues related to the maxillary premolars and molars are supplied by the greater palatine branch of the maxillary nerve, and the greater palatine foramen is usually located on the distal aspect of the maxillary second molar. So that's the nerve supply of the hard palate. Anteriorly, you've got the incisive branch of the maxillary nerve through the pterygopalatine ganglion, and posteriorly you've got the greater palatine branch of the maxillary through the pterygopalatine ganglion. The soft palate is supplied by the lesser palatine nerves, again branches of the maxillary through the pterygopalatine ganglion. And you can anesthetize the palate either through infiltration or giving nerve blocks related to the incisive nerve or the greater palatine nerve. We shall now look at various techniques for achieving anesthesia of the palatal soft tissues. As you know that the palatal mucosa is directly bound to the underlying periosteum. That is why we call it a mucoperiosteum. And uh, inadvertently, all injections on the palate are subperiosteal, and that is why they are so painful. So palatal injections are generally considered to be the most painful of all the injections in the oral cavity. So again, basic principles: inject slowly and inject a little volume. So that's important. So the commonest technique used for achieving anesthesia of the palatal tissues is infiltration, and you would require anesthesia of the palatal tissues when you're carrying out extractions or when you're doing periodontal procedures such as root surface debridement. Uh, for infiltration, you would uh, inject into the palatal tissues roughly a centimeter medial is towards the midline of the palate, medial to the tooth you are intending to operate upon, and you only need to penetrate 2 to 3 millimeters into the palatal tissues and inject uh, zero point 0.3 to zero point 0.4 mils of the anesthetic solution. And as soon as you see the palatal tissues blanch, and you can clearly see the pale white color of the palatal tissues due to vasoconstriction caused by adrenaline in the local anesthetic drugs we use commonly. So as soon as you see the palatal tissues blanch, that's when you need to stop, because excess of vasoconstrictor in the palatal tissues can cause severe uh, compromise of the blood supply to the palate and result in ischemic necrosis of the palate. So wherever you want to operate, you just need to inject zero point 0.3 to zero point 0.4 mils into the palatal tissues by injecting about a centimeter medial to the uh, marginal gingivae and uh, aiming close to the aiming to be close to the root apex. So it's a simple, straightforward technique, high success rate, and if you do need supplementary palatal anesthesia, by then the palatal tissues would have been anesthetized uh, at least partially, so the subsequent injections shouldn't be too painful. So it's a simple technique, and you should be able to learn it quite quickly. Although you do not need to administer nerve blocks on the palate routinely, but again they are fairly straightforward. So if you want to achieve anesthesia of the entire anterior hard palate, such as doing root surface debridement or multiple extractions, you can provide the incisive nerve block. So you can see the incisive papilla, the soft tissue projection, which demarcates the position of the incisive foramen, and all you need to do is apply topical anesthesia that is obviously applicable to all injections, and then you would insert your needle just on the lateral aspect of the incisive papilla. Do not attempt to insert your needle into the papilla because it would be more painful. And then penetrating 2 to 3 millimeters, you would inject approximately zero point 0.3 to zero point 0.4 mils of the anesthetic solution, and that should be enough to give you numbness of the anterior hard palate. For the posterior part of the palate, you would need a greater palatine nerve block, and you would attempt to insert the needle close to the distal aspect of the upper second molar, roughly 1 to 1.5 centimeter medial to the gingival margin. Uh, when we say medial, it's close to the midline. And again, Both these nerve blocks on the palate are very similar to infiltrations. There is no difference. You would use a short needle. You only need to inject zero point 0.3 to zero point 0.4 mils, and you only penetrate the tissues superficially, that is zero point 0.3 to zero point 0.4 millimeters. So in terms of the technique, it's very similar to an infiltration. However, uh, just have to be in the correct position. So for the incisive nerve block, you need to be adjacent to the incisive papilla, and for the greater palatine nerve block, you need to be close to the distal aspect of the upper second molar. Otherwise, the techniques are very similar to palatal infiltrations we discussed previously. Before discussing the local anesthetic injections in the mandible, we shall briefly review the applied anatomy of the mandible, and we shall be focusing on the nerves which are relevant to the administration of local anesthesia in the mandible. Now, as you would know, the mandibular division of the trigeminal nerve exits the skull via the foramen ovale and divides into an anterior and posterior division. The long buccal branch from the anterior division provides sensory innervation to the buccal soft tissues related to the molars, or in other words, all the buccal soft tissues, including the gingivae and the alveolar mucosae, posterior to the mental foramen. The inferior alveolar nerve from the posterior division of the trigeminal nerve, mandibular branch, supplies all the teeth in the mandible, anteriors, premolars, molars. The inferior alveolar nerve in the region of the lower premolars, specifically the lower second premolar, gives off a branch known as the mental nerve, which exits the mandible via the mental foramen and supplies the buccal soft tissues anterior to the mental foramen, and also innervates the skin on the chin. So in other words, the buccal soft tissues posterior to the mental foramen, that is the buccal soft tissues related to the lower molars, are supplied by the long buccal branch from the anterior division of the trigeminal nerve, and the buccal soft tissues anterior to the mental foramen, that is those related to the premolars, canines, and the incisors, are supplied by the mental branch which comes off from the inferior alveolar nerve, and all the teeth are supplied by the inferior alveolar nerve itself. The lingual nerve, which is another branch of the mandibular nerve from the posterior division, supplies all the lingual gingival soft tissues as well as the anterior two-thirds of the tongue and the oral floor. So these are the three important branches of the mandibular nerve which are relevant to the administration of local anesthesia in the mandible. The long buccal branch, the inferior alveolar nerve and the mental nerve, and the lingual branch of the mandibular nerve. The nerve to mylohyoid is not important in the context of local anesthesia. It mainly supplies the uh, anterior belly of digastric and the mylohyoid muscle, and is a motor nerve coming off from the inferior alveolar nerve. We shall now look at the techniques for administration of local anesthesia in the mandibular region. Like in the maxilla, infiltration anesthesia is useful for providing treatments in the anterior mandibular region. The mandibular bone is generally thinner in the anterior region, which allows the local anesthetic solutions to diffuse through the bone and reach the apical foramen of the teeth. Uh, so, if you are carrying out restorative treatments in the anterior mandibular region, like fillings and root canals, you would only require a labial or a buccal infiltration. However, if you are planning to extract a mandibular anterior tooth, in addition to the labial infiltration, you would also require a lingual infiltration to anesthetize the lingual soft tissues. Likewise, for periodontal treatments in the mandible, you would require a labial, buccal, infiltration plus a lingual infiltration, and you can accomplish periodontal treatments in the mandible, uh, both in the anterior as well as posterior region by buccal and lingual infiltrations alone. When carrying out invasive treatments involving the mandibular molars and premolars, you would require an inferior alveolar nerve block, and that would be adequate if you were to carry out restorative treatments such as fillings, root canals, or crown preparations on vital teeth. So you would only require an inferior alveolar nerve block for those procedures. However, if you want to extract a mandibular molar or a premolar, in addition to the inferior alveolar nerve block, you would also require anesthesia of the buccal soft tissues as well as the lingual soft tissues. So anesthesia of the buccal soft tissues in the mandibular molar region can be accomplished by a buccal infiltration alone, or if you want to anesthetize a larger area, that is, if you were to extract two or more mandibular molars, you can also use a long buccal nerve block, which would anesthetize all the buccal soft tissues posterior to the mental foramen. Uh, you also require anesthesia of the lingual soft tissues related to the mandibular molars and premolars for tooth extractions. However, both the inferior alveolar as well as the lingual nerves are enclosed within a space known as the pterygomandibular space, which is the space between the medial aspect of the mandibular angle and ramus area and the medial pterygoid muscle itself. Because the lingual and inferior alveolar nerves are localized in this space, administration of inferior alveolar nerve blocks would anesthetize the lingual nerves automatically. So you do not need a separate lingual nerve block. And finally, you can use a mental nerve block if you want to achieve anesthesia of the teeth anterior to the anterior to the mental foramen, as well as the soft tissues anterior to the mental foramen. And we shall discuss these in bit more detail now. So in order to achieve pain control for dental treatment on the incisors and canines, infiltration anesthesia is usually adequate in the mandible. So for restorative work, you only need a buccal infiltration, whereas for tooth extractions, you would need a buccal as well as a lingual infiltration. And when providing infiltration, the principles are similar. You align your injection needle along the long axis, parallel to the long axis of the tooth, and insert the needle for a few millimeters into the soft tissues close to the root apex of the tooth, just shy of the mucobuccal fold, and inject about 0.5 mils of local anesthetic solution. Invasive procedures on the premolars and molars in the mandible cannot be accomplished routinely using infiltrations alone, and therefore for restorative work you would require an inferior alveolar nerve block, and for tooth extractions you would require an inferior alveolar nerve block, a lingual nerve block which is achieved simultaneously, and a buccal nerve block or infiltration, and we'll discuss these in a bit more detail now. The inferior alveolar nerve block, also known as the inferior dental nerve block, is the only nerve block which is mandatory for you to learn during your undergraduate training. Uh, as you would know, the inferior alveolar nerve arises from the posterior division of the mandibular nerve, enters the mandibular foramen, and supplies all the teeth in the mandible, including incisors, canines, premolars, and molars. And through the mental nerve, it also supplies the buccal soft tissues anterior to the mental foramen and also the lower lip on either side. Uh, the inferior alveolar nerve is perhaps one of the more challenging uh, injection techniques in the mandible, and there is a 10% risk of failure to achieve anesthesia due to faulty technique with this nerve block. So it's something you would learn over a period of time because it requires considerable skill uh, to administer inferior alveolar nerve blocks. And as you can see in this picture, if you were to administer an inferior alveolar nerve block, it would anesthetize all the teeth in the mandible on one side, the buccal soft tissues anterior to the mental foramen, and also the lower lip. What is also interesting to note is that with an inferior alveolar nerve block, you would also simultaneously anesthetize all the lingual soft tissues, the anterior two-thirds of the tongue, and the oral floor, because the lingual nerve is confined within the pterygomandibular space, and when you administer an inferior alveolar nerve block, you would simultaneously anesthetize the lingual nerve without the need for any additional injections. In order to understand the technique for the inferior alveolar nerve block, we shall briefly revisit some of the relevant anatomical features of the mandible. So you should be familiar with the ramus of the mandible, the angle region, uh, the mandibular foramen on the medial aspect of the mandibular ramus, the lingula, which is a little bony projection covering the mandibular foramen partially, and obviously the inferior alveolar nerve is going to enter the mandible through the mandibular foramen, and a branch is going to exit through the mental foramen. So you should know all that. What is most relevant to the inferior alveolar nerve block is the coronoid notch, which is the deepest concavity along the anterior border of the mandibular ramus. And if you look at the position of the coronoid notch, it is roughly at the same level as the mandibular foramen, and we shall use this bony landmark uh, to learn the technique for the inferior alveolar nerve block. So remember this coronoid notch, which is the deepest concavity on the anterior border of the mandibular ramus, and it is roughly at the same level, at the same height as the mandibular foramen. So keep in mind the coronoid notch. This slide depicts some of the important anatomical structures which are relevant to the administration of an inferior alveolar nerve block. So just to orient yourself, this is the anterior side towards the lips, the posterior, medial towards the tongue, and lateral towards the cheek. R is the mandibular ramus, and as you know, uh, on the lateral aspect of the mandibular ramus, you've got attachment of the masseter muscle, and on the medial aspect of the ramus and angle region, you've got the medial pterygoid muscle. And the space between the medial aspect of the mandibular ramus and the medial pterygoid muscle is known as the pterygomandibular space. And the inferior alveolar nerve and lingual nerves, uh, they are enclosed within this space known as the pterygomandibular space. It's marked anteriorly by a fold of soft tissue, which is known as the pterygomandibular raphe. This you will see more clearly in the following slide. Uh, this pterygomandibular raphe is basically a soft tissue fold formed by the union of the tendons of the buccinator muscle anteriorly and the superior constrictor muscle of the pharynx posteriorly. And it's an important landmark for your inferior alveolar nerve block. We'll see that in a minute. Within the pterygomandibular space, you've got the inferior alveolar nerve and the lingual nerve. Now, mind you, the inferior alveolar nerve is not just the nerve in isolation, but it is a neurovascular bundle which contains the inferior alveolar nerve, the inferior alveolar artery, and the inferior alveolar vein. So therefore, it's important that when you administer an inferior alveolar nerve block, you must always aspirate because you are in the vicinity of a blood vessel, and there is a risk that if you do not aspirate, you may accidentally inject into the blood vessel directly, which can have serious side effects on the cardiovascular system because of the high concentration of the local anesthetic. So that is why you must always aspirate. Another point to remember is that the inferior alveolar nerve is roughly at a depth of 2 to 2.5 centimeters in the pterygomandibular space, whereas the lingual nerve is a bit more anterior and a lot more superficial, roughly zero point 0.5 to zero point 0.8 centimeters in the pterygomandibular space. So when you administer an inferior alveolar nerve block, because both nerves are contained within the same space, a single injection uh, aimed at providing anesthesia for the inferior alveolar nerve would simultaneously anesthetize the lingual nerve, and contrary to the old belief, you do not need a separate lingual nerve block. So these are some of the important landmarks which you must bear in mind when you consider the technique for an inferior alveolar nerve block. The last thing is the parotid gland is retromandibular in position and very close to the injection site for the inferior alveolar nerve block. So when you insert your needle into the pterygomandibular space, always make sure that you do not go too deep, otherwise you'll be very close to the parotid gland, and because the parotid gland contains branches of the facial nerve, you could cause paralysis of the facial nerve, uh, which would obviously need to be recorded as a clinical incident and is highly undesirable. So we'll talk a bit more about the depth of needle penetration in the later slides. We shall now review some of the key anatomical landmarks as they would be utilized during administration of an inferior alveolar nerve block. So the first one is the coronoid notch. As discussed previously, the coronoid notch is the deepest concavity on the anterior border of the mandibular ramus, and obviously you can't see the coronoid notch visually in the oral cavity due to the presence of the soft tissues, and it's something you would palpate with the non-dominant hand using your thumb. So localize the uh, deepest concavity on the anterior border of the mandibular ramus. That's the coronoid notch. And if you bisect it, it will give you the height of the injection because it is level with the height of the mandibular foramen on the medial aspect of the mandibular ramus. So that's the first anatomical landmark. The second is this fold of tissue, soft tissue, the pterygomandibular fascia or the pterygomandibular raphe, where the buccinator and the superior pharyngeal constrictor muscles join. And this fold of tissue runs on the lingual aspect all the way towards the uh, palate. And the third one is a depression. This is a depression you would visualize in the soft tissues. Um It can be ovoid, it can be linear, it can be circular. Sometimes it's very prominent, sometimes less so. But in any case, just lateral to the pterygomandibular raphe, you would identify a depression in the soft tissues, which is known as the pterygotemporal depression. Now, that is the point of your needle penetration with your inferior alveolar nerve block. And fourthly, you would identify the occlusal plane on the mandibular teeth with the patient's mouth wide open as you would be approaching the pterygotemporal depression from the opposite premolars with your injection. So remember these four anatomical landmarks: the coronoid notch, the pterygomandibular raphe or the fascia, the pterygotemporal depression, and the occlusal plane on the contralateral premolars, mandibular premolars. We shall now try to learn the basic technique for administration of an inferior alveolar nerve block, and following this presentation you should watch the video demonstrations which show the appropriate use of safety plus syringe plus the technique for administration of an inferior alveolar nerve block, and these video demonstrations should be available on the DLE and then at a later stage you will get opportunities to consolidate your skills in local anesthesia, both in CIDL as well as on clinic. So we'll be discussing the direct technique for an ID nerve block. Obviously, there are alternate techniques such as uh, the indirect technique and the Gauge block. However, at this initial stage, you need to focus on one technique so you can practice it and consolidate your skills, and then you can learn about other alternate techniques at a later stage in your career. So the first thing would be to palpate the coronoid notch, the deepest skin cavity on the external oblique ridge, by placing the thumb on your non-dominant hand on the coronoid notch, and then you will approach the injection site from the contralateral premolars with the patient's mouth wide open. You will place the barrel of your syringe on the contralateral premolars, staying fractionally clear of the occlusal plane, and then you would attempt to insert your needle lateral to the pterygomandibular raphe, this fold of tissue, into the pterygotemporal depression, so that your needle penetration is roughly 2 centimeters posterior to the height of your thumbnail. Now, towards the lip is anterior and towards the soft palate is posterior. So roughly 2 centimeters posterior to the height of your thumbnail, you would insert the needle. Just to remind you that you would be using a 35 millimeter needle for your inferior alveolar nerve blocks, and the inferior alveolar nerve is approximately 2 to 2.5 centimeters deep in the pterygomandibular space. So under no circumstances you should insert your needle more than 2.5 centimeters. In other words, 1/3 of the needle should always be outside the tissues. Otherwise, you will be too close to the parotid gland and the branches of the facial nerve, and you can cause a facial nerve paralysis. So therefore, one of the more important points during ID nerve blocks is that your needle penetration should be no more than 2/3 of the needle length, given that you're using a 35 millimeter needle. So you would advance the needle into the pterygotemporal depression, and at a depth of 2 to 2.5 centimeters, you would expect to encounter bony resistance, which would imply that you have uh, hit the medial aspect of the mandibular ramus with your needle. And then at that point, you would withdraw your needle for a couple of millimeters, you would retract it, and then aspirate, wait for the result of the aspiration for a few seconds before you inject roughly 1.5 mils into the pterygomandibular space. And if your needle position is correct, you should be able to achieve an inferior alveolar nerve block plus the lingual nerve block with a single injection. The inferior alveolar nerve block can be verified by confirming numbness involving the lower lip and the chin on the side of the injection. And for the lingual nerve block, you can confirm it by uh, checking numbness on the uh, anterior 2/3 of the tongue on one side and the lingual gingivae. So once you've administered 1.5 mils, you would withdraw your syringe and then wait for 3 to 5 minutes for the injection to be fully effective. Now, just in case when you insert the needle and you encounter bony resistance too early, say you've just penetrated uh, 0.5 centimeters into the tissue and you encounter bony resistance, that would imply that your needle is close to the external oblique ridge and you're not in the right place in the pterygomandibular space. In such cases, it's best to come out and then repeat the injection again by reorienting your needle. Similarly, if you do not encounter any bony resistance, even after sticking the needle 2/3 up its length, that would imply that your needle is too close to the parotid gland and you can paralyze the facial nerve. So therefore again, best to come out and repeat the injection again. So just to repeat again, you would approach the injection site from the contralateral premolars and place your thumb on the coronoid notch, bisect the height of your fingernail and penetrate lateral to the pterygomandibular raphe into the pterygotemporal depression, bisecting the height of your fingernail 2 to 2.5 centimeter posterior to the height of your thumbnail, and then you would hope to encounter bony resistance at a depth of 2 to 2.5 centimeters. We shall now look at the long buccal nerve block. As mentioned before, the long buccal nerve from the anterior division of the trigeminal nerve, mandibular branch, supplies the buccal soft tissues related to the molars, or in other words, the buccal soft tissues posterior to the mental foramen. The technique for a long buccal nerve block is quite straightforward. So you palpate the anterior border of the mandibular ramus uh, and then inject the local anesthetic adjacent to the distobuccal cusp of the last standing molar. Obviously, if the molars are missing, you will have to account for that when adjusting your needle position for a long buccal nerve block. But in dentate patients, you penetrate the soft tissues adjacent to the distobuccal cusp of the last standing molar, and you only need to penetrate 4 to 5 millimeters into the mucosa. So basically, the long buccal nerve is quite similar to an infiltration. It's just where you position the needle when injecting into the soft tissues. So that's the long buccal nerve block, quite straightforward, just like an infiltration. And it would allow you to anesthetize the buccal soft tissues related to all the mandibular molars with a single injection. So it can be quite useful. You're also expected to complete clinical notes on LA administration, and these are part of your capability assessment. A template is available on R4 and you can look it up later, but basically you should confirm that you have an informed consent from your patient, both for LA administration and any treatment you may be carrying out in that session. In addition, you should include details of the LA. So you should include the local anesthetic agent used. So for example, 3% mepivacaine hydrochloride plain, which is available commercially as Scandonest, or the one we use more commonly, 2% lignocaine with adrenaline 1 in 80,000. You should also include the batch number and the expiry date on each local anesthetic agent used in a treatment session. You should also mention the site, so the upper left premolar, and the type of local anesthetic injection given. So for example, buccal infiltration or palatal infiltration, and the volume of local anesthetic administered. So for example, 0.5 mils. Obviously, these details will depend upon what you've actually administered, but this is just an example. Similarly, if you've administered a lower left inferior alveolar nerve block, make sure you mention the side, left or the right, and the volume as well. So for each injection given, you should include the site, the volume, and the type of injection you've given, infiltration or a nerve block. And as I mentioned, these will be assessed during your capability assessment, which will be done at a later stage. And finally, you should be able to provide appropriate post-operative instructions to your patient following LA administration. These are primarily aimed at preventing soft tissue trauma. As the mouth may be numb for up to 2 hours, it can take anywhere between 1 to 3 hours for local anesthetics in the mouth to wear off, but on an average, 2 hours is appropriate. So let your patients know that their mouth or face may be numb for up to 2 hours, and during this period, they must avoid hot drinks or food which may burn the soft tissues such as the lip or the tongue, and they should also consciously avoid biting their lips, cheek, or the tongue. And if they experience any post-operative uh, trauma to the soft tissues, they must report back to you for a review appointment.